Ramavath Abhilash. I'm a second-year medical student. May I know your name, please?
Sure.
Okay, what's your age?
21.
Okay, today I'm going to examine your sensory system. Is that okay with you?
Okay.
Okay, can we start now?
Yes.
Now use a sharp safety pin, the stick portion of a broken swab, or other suitable tool. Occasionally substitute the blunt end for the point. Ask the patient, is this sharp or dull? Or when making comparisons, does this feel the same as this? Apply the lightest pressure needed for the stimulus to feel sharp. Avoid heavy pricks that draw blood. To prevent transmitting a bloodborne infection, discard the pin or other device safely. Don't reuse it on another person. Analgesia refers to absence of pain sensation. Hyperalgesia refers to decreased sensitivity to pain, and hyperalgesia refers to increased pain sensitivity. Now, light touch. With a fine wisp of cotton, touch the skin lightly, avoiding pressure. Ask the patient to respond whenever a touch is felt and to compare one area with another. Avoid touching colored skin, which is normally relatively insensitive. Anesthesia is the absence of total sensation. And now proprioception. Grasp the patient's big toe, holding it by its sides between your thumb and index finger, then pull it away from the other toes. This prevents extraneous tactile stimuli from affecting testing. Demonstrate up and down as you move the patient's toe clearly upward and downward. Then, with the patient's eyes closed, ask the patient to say up or down when moving the large toe in small arc. Now repeat the test several times on each side. If position sense is impaired, move proximally to test the ankle joint. In a similar fashion, test position in the fingers, moving proximally if indicated to the metacarpophalangeal joints, wrist and elbow. Stereognosis refers to ability to identify an object by feeling it. Place a familiar object such as coin, paperclip or eraser in the patient's hand and ask the patient to tell you what it is. Normally a patient will manipulate it skillfully and identify it correctly within 5 seconds. A stereognosis refers to the inability to recognize objects placed in the hand. Now, number identification, graphesthesia. If arthritis or other conditions prevent the patient from manipulating an object well enough to identify it, test the ability to identify numbers. With a blunt end of a pencil, draw a large number in the patient's palm. A normally able person can identify most such numbers. And now 2 point discrimination test. Using the two fingers of an open paper clip or two pins, touch a finger pad in two places simultaneously. Alternate the double stimulus irregularly with a 1 point touch. Be careful not to cause pain. Find the minimal distance at which the patient can discriminate one from 2 points. Normally, it should be less than 5 mm on the finger pads. In point localization, briefly touch a point on the patient's skin. Then ask the patient to open both eyes and point the place touched. Normally, a person can do so accurately. Lesions of the sensory cortex impair the ability to localize points accurately. Now, in extinction, stimulate one side or simultaneously stimulate corresponding areas on both sides of the body and ask where the patient feels your touch. Normally, both stimuli are felt. In reinforcement, if the patient reflexes are symmetrically diminished or absent, use reinforcement, a technique involving isometric contraction of other muscles for up to 10 seconds that may increase reflex activity. Ask the patient to clench teeth and squeeze both knees together, and ask the patient to lock fingers and pull one hand against the other. Now test for biceps reflex. The patient's elbow should be partially flexed and the forearm pronated with palm down. Place your thumb or finger firmly on the biceps tendon. Aim the strike with the reflex hammer directly through your digit towards the biceps tendon. Observe flexion at the elbow and watch for and feel the contraction of the biceps muscle. And also test by patients lying down. Now test for triceps reflex. The patient may be sitting or supine. Flex the patient's arm at the elbow with palm toward the body and pull it slightly across the chest. Strike the triceps tendon with a direct blow directly behind and just above the elbow. Watch for contraction of the triceps muscle and extension of the elbow. In brachioradialis reflex, the patient's hand should rest on the abdomen or the lap with the forearm partly pronated. Strike the radius with the point or flat edge on the reflex hammer about 1 to 2 inches above the wrist. Now watch for flexion and supination of the forearm. And now quadriceps or patellar reflex. The patient may be either sitting or lying down as long as the knee is flexed. Briskly tap the patellar tendon just below the patella. Note contraction of the quadriceps with extension at the knee. Place your hand on the patient's anterior thigh. Lets you feel the reflex. There are two options for examining the supine patient. Supporting both knees at once allows you to access small differences between quadriceps reflexes by repeatedly testing one reflex and the other. If supporting both legs is uncomfortable for you or the patient, you can place your supporting arm under the patient's leg. Some patients find it easier to relax with this method and perform the same in the opposite leg. Now the Achilles or ankle reflex. If the patient is sitting, partially dorsiflex the foot at the ankle. Persuade the patient to relax and strike the Achilles tendon and watch and feel for plantar flexion at the ankle. Also note the speed of relaxation after muscle contraction. And now perform by the patient is lying down. Dorsiflex the foot at the ankle and strike the Achilles tendon. And now the clonus. If the reflex is seen hyperactive, test for ankle clonus. Support the knee in a partly flexed position with your other hand. Dorsiflex and plantar flex the foot a few times while encouraging the patient to relax. Then sharply dorsiflex the foot and maintain it in dorsiflexion. Look and feel for rhythmic oscillations between dorsiflexion and plantar flexion. There may be a few clonic beats if the patient is tense or exercised. Now the abdominal reflexes. Touch the abdominal reflexes by briskly stroking each side of the abdomen about T8, T9 and T10 and below from T10, T11 and T12. The umbilicus in the directions. Note the contraction of the abdominal muscles and movement of the umbilicus towards the stimulus. Now in plantar response, with a key or the wooden end of an applicated stick, stroke the lateral aspect of the sole from the heel to the ball of the foot, curving medially across the ball. Use the lightest stimulus needed to provoke a response, but increase firmness if necessary, and closely observe movement of the big toe, normally plantar flexion. A marked Babinski response is occasionally accompanied by reflex flexion at hip and knee.
Okay, now this completes your complete examination of sensory system, and thank you for your cooperation.